Assalamualaikum. I am Dr. LIZA Ali from Online Learning TAWAKKUL group, and today is 3rd November, Monday, and we are going to do this CPTSB question from volume 27 and issue 3. And today our topic of discussion is uh, mm, this what we call it, this acute fatty liver of pregnancy. Okay, so these are the MCQ which we are going to do it today. So the first question is the acute liver disorder in the third trimester. This is the actual topic name. So what is the question is that with regard to the etiology of the acute fatty liver in pregnancy, the long chain 3-hydroxyl coenzyme A dehydrogenase deficiency increases the risk. So the this will be the true or the false. So the answer is true. He say yes, this is the long chain hydroxyl acyl hydroxyacyl coenzyme A dehydrogenase. So LCHAD deficiency, it will increase the risk of acute fatty liver of pregnancy. This is the thing in fetal maternal genetic interaction. Why they say this is because it will interact both maternal and the fetus. This is the first thing. And the second question is that, my friends, these are all the questions from the this talk article. Okay, we are going to give the answer. The second question is that it is more common in morbidly obese, means our point is that this acute fatty liver in pregnancy is more common in obese women, true or false? So answer is false. It is not more common in the morbidly obese woman. No, morbidity obesity is not a risk factor for acute fatty liver of pregnancy. In fact, low body mass index is the listed risk factors. So we have to know this is not more common in obese women. It is mostly in the means low body mass index, thin ladies. Okay ji. If we will go for the risk factors, other risk factors are the multiple pregnancy, younger and older, maternal age group, gestational hypertension, male fetus, sorry, and if she is carrying a male fetus, and if she is having a deficiency of long chain 3-hydroxyl CoA dehydrogenase LCHAD, the one which we done the question. So these are the risk factors. Okay, the third question is that with regard to the acute fatty liver in pregnancy, over 90% of cases occur in the third trimester. So the this will be the true question, true or false? Not true. This is true. The most common presentation, fourth question is that most common presentation of acute fatty liver in pregnancy is abdominal pain. So this is true. Okay, this is over 90% of acute fatty liver occurs in the third trimester, 90%. Okay, and abdominal pain is more common presentation. This we already done. Okay, regarding the HELP syndrome, this is the fifth question, number 5. It is preceded by preeclampsia in over 90% of cases. So this is true. This statement is true. According to that one, the question is that means sometimes the statement is complication of HELP syndrome is a complication of preeclampsia, and it is preceded by the preeclampsia in over 90% of cases. Okay. So question number 6 that it occurs in up to 30% of cases postpartum. This is also true. Yes. So because you see, if it is, we say 90 to 70% it occurs in the pregnancy, so the 30% they occur after the pregnancy. Okay. Yes. 70% we can say. Okay. And the increased risk of metabolic disorders in later life, means this they have an increased risk of metabolic disorders in later life. True. Okay ji. The liver transplantation is the treatment option in those women with hepatic rupture with regard to acute viral hepatitis in pregnancy. So the answer will be false. Liver transplantation is the treatment option for acute failure. Okay, liver failure, acute liver failure in pregnancy, which is very rare, but it is a life-threatening condition, and this is not a routine treatment for the viral hepatitis. Because you see here what he is talking that she has a hepatic rupture after acute viral hepatitis. So this is not common in that area. Question number 9. Infection with hepatitis E is associated with the highest mortality morbidity among the hepatitis virus. So this is true. Yes, it has to be because hepatitis E is more dangerous than the B and the C. E is more dangerous. And that question number 10 is that treatment with the nucleoside based medication is not recommended in pregnancy. Yes, true. We are not recommend this medication in the pregnancy. There is also SBA, one SBA there. A 30 years old primary gravida at 30 week of pregnancy attend the maternity emergency unit with malaise, nausea, vomiting and right upper quadrant pain. Initial assessment suggests she is having a preeclampsia and subsequent investigation shows that she is having a HELP syndrome. Already we know it that the HELP PAT preceded by the HELP syndrome. So the Mississippi class 1 upon examination what she is having, her BP is 120/70, pulse is 90, temperature 37. Which of the following is the most crucial immediate management? What the management will do? Cesarean section, corticosteroid, induction of labor, labetalol, magnesium sulfate. Means what is the most important in because she is 30 week pregnant with HELP syndrome. So what we'll do? We will give her the corticosteroids to make the precaution. Maybe she will dead because right now there is not an acute emergency. There is no problem for the baby to be delivered in emergency. Mother having a malaise and the nausea and the vomiting and the pain. We have to manage this pain. Then we will think of the delivery, or otherwise she can have a acute condition that need to be delivered baby. Then we will do the acute measures. Right now there is nothing there, so answer will be corticosteroid. Immediate management is stable the primary gravida at 30 week with HAL syndrome is the administration of corticosteroids. So it will give the time to accelerate fetal lung maturity before delivery, and which is definite treatment of HAL syndrome. Okay. Okay, this the one, and another the last question is this last SBA. Right now, because it is this, these are the all the MCQs, and this is another SBA, the last question of this acute fatty liver in pregnancy. A 26-year-old primary gravida, she is 28-week pregnancy, and she came to the maternity emergency department with a history of fever, fatigue, nausea, vomiting, and the right upper quadrant pain. Upon examination, she is jaundice, liver tender on palpation. Her ALT is 800 international unit per liter. And these are the values they give in AST is 750. So it is increased. So question is that what is the most appropriate immediate management step for this patient? So they want to know. They say, okay, administer hepatitis A immunoglobulin to the patient. That the B is advised immediate termination of the pregnancy to prevent fetal transmission. C, initiate immediate treatment with intravenous acyclovir and prepare for the urgent delivery due to the maternal hepatitis. And the last question is that provide support care, close monitoring of liver, LFT and coagulation and fetal length. So the answer will be E. We have to provide the support care to the appropriate management care, fetal monitoring, liver function test. We have to do this thing. That's all. Thank you so much.